All right, can somebody read this paragraph for me out loud?
Truth be told, the past is stable. What happened happened. No. One can change history. How is it remembered? How is it reported? How is it felt or interpreted? How we regard it and different viewpoints toward it can all change, but the facts of the past are permanent. No matter how hard we try or how good our tools, the good news is, though, that we can change the effect the past continues to have on ourselves and our clients now and in the future. That is really the aim of trauma recovery. Rothschild, 2017.
Thank you, Jessica. Talk to me about what do you get from this quote? What are the things that stand out to you?
I think that there's a very strong subjective um, framework that we create that is, it's not even a one and done. It's like it's constantly shifting, which means it constantly recontextualizes not only our understanding, but what we gain and grow from it.
Very good point. Trauma is very subjective. Yep, very much so, which we'll learn about in this class, why it's subjective. Does anybody have an example of how a traumatic incident can be subjective?
Is that the idea where if you have two siblings go through the same event, they're each of them have a different outcome?
Yeah, absolutely. So what's
I,
real, go ahead.
no, I'm sorry. I was thinking about this the other day. I was in Iraq and we got into a firefight, and the radio guy who was safe in the fob was listening to what was going on, what we were doing, and he got PTSD and had to get sent home.
Mm-hmm.
But we who were out there on the ground were pretty much fine. And I
Mm-hmm.
think it was the fact that the unknown of what was going on was just too overwhelming for him, where we
Mm-hmm.
were working as a team and kind of fell into our roles. So
Mm-hmm.
we felt safer in the immediate danger than
Mm-hmm.
he did in imagined danger.
Mm-hmm. That's such a great example. Thank you for sharing. And that's one thing that we're going to learn in this class is how one person is impacted by trauma is very different and unique than how somebody else is impacted by it. And the truth is that there are just facts that happen. And so even though the facts, the trauma happened, what we can do is we can, as clinicians, help a client change the way that the trauma continues to impact the client. One thing that's very, very important when you're treating trauma is to understand that the traumatic incident is going to impact everybody differently. If you have had a traumatic experience and a client has went through the exact same experience, kind of the example you were giving, to not project your trauma onto a client. I had a client that I was working with. I'm gonna talk graphic. So if there's any kiddos around, earmuffs. There was a client I was working with, and her mom shot herself. Her mom committed suicide in my client's car with a gun. That would probably mess me up for a very long time if my mom killed herself in my car as a teenager. The client has gone through so much trauma. That wasn't the trauma that kind of set her off. What caused her the most distress was at the time her boyfriend, who was her main support system, breaking up with her. Now, did her mom ending her life by suicide impact the client? Yes. But was causing the client the most distress was her boyfriend breaking up with her. Point is, when you hear a client tell their story, it's very important that you let them tell you what part of their story causes them the most distress. And it's traumatic for the client. Even if you have a different opinion, if you have a different experience, we meet the client where they're at. Now I've been treating trauma for 20 years. working with kids in foster care, working with individuals who are survivors of human trafficking. I've seen probably everything. I've heard the worst, horrible, horrible stories, especially with little kids, from babies to toddlers to teenagers. Um, I've heard it all. And one of the trauma treatments is hearing your client's story in detail. So I've heard a lot of detail. So I'm currently working with the client right now. And when she talks to me about her trauma, I have a hard time calling her situation trauma. She says that she was yelled at by her dad, and her dad was angry. Now, that is probably traumatic and that doesn't feel good, but the level of distress that my client reports to me, I was like, this doesn't really feel proportionate. But I have to remind myself it's not about necessarily the severity of the trauma incident, it's how it impacts the clients. So I have to reset and treat the client exactly how I would treat any other client that reports to me a traumatic incident. Does anybody have any questions about that or thoughts? Does that make sense? Yes, Jessica.
How do you validate something like that? Just the same way you would validate something that feels proportionate to you? Or is there a story you have to tell yourself to help you not laugh sometimes?
So, the intervention that I do is, if you can really grasp unconditional positive regard and accurate empathic understanding and learn to see it through the client's lens, it is easier to know how to respond to a client if I'm constantly thinking my goal is empathy. My goal is to really seek to understand it from the client's lens and to ask questions, to gain awareness to why it was a problem for them. So what I do is I ask a lot of clarifying questions and a lot of attunement. Now that thought popped up in my head of, oh my gosh, like I've heard so many more traumatic stories, and it's just a quick reset in my brain of the work that I'm doing of how to treat the client's trauma.
Thank you.
Okay. Okay, so trauma. Now there are, I think the word trauma gets thrown around a lot, just like the word gaslighting gets thrown out. There's like buzzwords that seem to be floating around social media that are overused. I definitely think we're getting better at being trauma informed. But I'm just going to help us to think clinically, there are definite definitions of what defines a traumatic incident versus like a crisis situation. And so a trauma is something that, and if we look in the DSM, we're actually going to go through this in a little bit, but the DSM is very specific on what constitutes a traumatic event. So I'm just going to go right here. So for the DSM, it's direct exposure, witnessing a trauma, learning that a relative or close friend was exposed to a trauma, or indirect exposure to details about the trauma. And usually the traumatic incident is a threat to yourself, a physical, emotional threat to yourself, threat to somebody else. It can be physical. It can be sexual. It can be domestic violence. It can be community violence, workplace violence, school violence. It can be a medical or a mental health related trauma. A medical trauma is, I had a client that went to the hospital and she was, if I can remember this, it was actually a while ago, but she was talking about having surgery and then like I think her anesthesia wore off. Or no, she was like awake and then she saw the surgeons perform the surgery on her and she was awake. She couldn't feel any pain, but that was traumatic for her to wake up mid-surgery and to see work being performed on her. Um, what some of the researchers say is that 1 out of 5 individuals met the criteria for PTSD due to the pandemic. There is a book out there called it's called oh, why is my brain not working right now? I will remember the title of the book. I think it's like The Psychology of Pandemics, and it was published before COVID. But it talks about how from the history of time, a lot of these major outbursts and outbreaks and pandemics have caused a lot of the same psychological responses such as COVID did. But 1 out of 5 individuals met the criteria for PTSD due to the COVID pandemic. Acts of terrorism, war, natural and human-made disasters, weather disasters, homicides, suicides, motor vehicle accidents. So these are some of the types of trauma. Yes, Steve.
Yeah, about the COVID-19, I was listening to a podcast the other day, and they were talking about not just the pandemic itself, but the societal reaction to it and how we were split over it.
Yep.
Would that be considered in that same basket?
So let's say you had a individual who uh, lived by themselves and they didn't have a support system. And then they had to isolate and to quarantine. And let's say that in itself, they weren't able to see um, like their support system. And so the loss of community for that person could be the thing that caused them to have that experience something traumatic. It could be, I know for myself, I didn't get to go to my grandma's, my grandma passed away and I didn't get to go see her and say goodbye. That don't necessarily was traumatic, but if you have a different opinion than somebody, maybe that caused like a loss of a really close relationship. So what we're going to learn in this class is it's the traumatic event in itself is distressing, but it's also the meaning making that we create from the traumatic event. And it really is how it impacts us. So part of the work that you're going to be learning, I'm kind of giving an overview of this class today, but what we're going to be learning in great detail is why does it impact some people and it doesn't impact other people, and what are some of the protective factors, and when you're treating trauma, what are the specific symptoms you're looking for to treat. And a lot of that is meaning making. What is the client telling themselves about the event and how it has changed the way that they see themselves, the world, and others, and God as a result of it. That's a lot of the work we're going to be diving into. So, a lot of people experience something traumatic, and it's a very normal, natural response to have like an emotional response to a traumatic event. That doesn't mean that you have PTSD. That doesn't mean that you meet the criteria for a PTSD diagnosis. When there's something traumatic that happens, you should have a emotional response to the traumatic event. There is a family we're working with where the dad committed suicide in the backyard of their family home. And the mom called us immediately. She's like, I need to get my kids into counseling. And so I was asking her about, what is it that she's seeing? She's like, my son and my daughter, they're crying. Now they didn't witness the incident, they heard about it. They're crying, they want to talk about it, they're processing it, they're grieving. And so as a clinician, I'm like, that's a good thing. That's a normal response. What happens though is a lot of individuals, we don't like feeling distress. We don't like feeling sad feelings. Um, and so we try to shove it down, but you should have some emotional big feelings to a traumatic event that happened. So you have the traumatic event, and then there's emotional response to the traumatic event. And what we're going to talk about in this class is then what then constitutes, when does it become pathological? When does it become so dysfunctional that you actually need now mental health treatment? Just because somebody experiences something traumatic doesn't in itself mean that they need to go see a mental health professional. And we'll get all into that in this class. Okay, so we talked about different people experience and live through different traumatic events in many different ways, many different types of trauma. Um, how do some people cope with it? Is you're and there's a video in this week. It's how the brain responds to trauma. It talks about the parasympathetic nervous system and how it actually changes parts of the brain, but you have your system becomes dysregulated. Have you ever been in a conversation with somebody where things get really escalated and get really triggered? And you're like, why in the world am I this escalated or triggered in this moment? Where it doesn't necessarily seem proportioned to the content. Has it happened to anybody before? That's your nervous system being dysregulated because, as we're going to learn in this class, Dr. Vanderkolk talks about the body keeps score, is that your body remembers the traumatic event. So even though you're currently safe, if your body detects any type of stress response, if your body remembers some type of stressful event, your body's probably going to kick in before the logical part of your brain kicks in. Here's an example. Um, if you were to see a toddler run into the middle of the street, let's say it's a busy street, tons of cars, and you see a toddler run into the middle of the street, what's going to be your first response?
Chase them down.
Chase them down. Are you going to stop and think, oh, I'm wondering how fast this car is going? If the car is going 26 miles an hour and my kid's running 2 miles an hour, then I don't think they're gonna meet. Is your brain gonna stop and think that? It's gonna have an automatic response because so what happens is the way that our body and our brain is designed, our body kicks in for survival. And so if you see a toddler running into the street, your brain is not designed to think logically in that moment. Your body's designed to kick in for safety to protect your toddler. The same thing happens to us in everyday life where our body kicks in, our body thinks, okay, something bad might happen, or this particular incident or situation or person reminds your body that something is not safe or not right. So your body kicks in. It actually decreases your ability to think rationally by 75%. There's a whole video of this that I uploaded in the next couple of weeks that goes into this the brain science in more detail. Also, a response is not sleeping, numbing out. So who wants to walk around thinking about horrible memories? Who wants to walk around remembering and replaying horrible things to happen? One of the symptoms of PTSD, which you're going to learn about, is avoidance. You don't want to talk about it. You don't want to remember it. However, it's still there. It still comes up. So one of the ways that people cope with it is they numb out, is they avoid. Also, feeling of hopelessness, helplessness, flashbacks, nightmares, self-loathing, shame. Shame is a huge one. I think shame is one of the main reasons why individuals get stuck because of trauma, is because number one, they think that they may have caused it, that they did something to contribute to it. They didn't stop it. Even sharing this story out loud brings a deep part of shame. And so shame is one of the main reasons why I think it keeps somebody stuck. And then in addition to shame, when you feel something shameful, you don't want to talk about it and you don't want to share it. So it keeps people stuck. And then one of the ways we can help a client out of that shame is with accurate empathic understanding, deep empathy, unconditional positive regard. So when you share your shame and you share your story and you're met with empathy and attunement, that as part of the healing work. Okay, hypervigilance, mistrust. Hypervigilance is you're constantly on edge. Your body is scanning for threat. So the amygdala, which is part of the brain that alerts us when there's a trigger, the amygdala cannot tell the difference between a perception of a threat or an actual threat. Let's say you have a fear of snakes and you go on a hike and you hear something rattling in the bush. If your brain thinks it's a snake, it's automatically going to jump to protect yourself. And maybe it's like a little small mouse or something. But the amygdala cannot tell the difference between a perception of a threat or an actual threat. Panic attacks, social anxiety, addictions, eating disorders, suicidality, self-harm. Trauma can lead to borderline personality disorder, anxiety, and depression, decreased concentration. I was working with a client who was reporting ADHD symptoms, and she wanted to come in because she thought she had ADHD. The more work I was doing with her, come to find out she had pretty significant trauma where she was in a abusive relationship for 6 years, where her boyfriend beat her so severely that she almost died on a couple of occasions. In addition, she was molested by her uncle, who was her doctor. Her uncle was her pediatrician, who molested her when she was about 10 during physicals, and then she was kidnapped. But she shoved it down, didn't want to talk about it, repressed it, and then started reporting ADHD symptoms, poor concentration, not being able to sleep. So once we're able to talk more, figure out, hey, this really is PTSD that we're dealing with versus ADHD, even though they can look very similar. Okay, already went through here. So as I mentioned, about 70% of individuals have experienced something traumatic, but only 6% of individuals go on to develop PTSD. I think the research shows it's a little bit higher now, about 10%. And we'll go into that more in this class of why that is. But the purpose of me saying this is just because someone has trauma in their history doesn't mean you're going to treat it as PTSD. What I'm going to train you all in this class, hopefully, is how to recognize if it's PTSD, if it's acute stress disorder or adjustment disorder, because how you treat that is very separate and unique than how you would treat another diagnosis, which we're going to cover in this class. So I'm training you to listen for just because somebody has trauma doesn't mean they're going to have PTSD. And then once we learn more about PTSD, we'll learn about the very specific things that the client needs in order to be treated for their trauma, which we'll get into.
Do you know what the percentage of recovery is from PTSD?
So, recovery is a great question, and I think recovery is subjective. Your brain is always going to alert yourself when there is potential danger. So the trauma recovery really is learning how to recognize and managing the symptoms so they become less frequent and less intense. Part of the frustration that clients feel is, oh, I had another trauma response. And so for them, recovery might be, I don't want any trauma responses. And so what I gently help them understand is your body's doing what your body's designed to do. Your body's trying to protect yourself and to keep it safe. Once we can recognize, oh, there it is. My body's trying to protect me. They can recognize it and then they can learn to cope with it. So the goal is to increase the window of tolerance to the distress, not so much to eliminate it. So recovery for the client really is kind of subjective also, in the sense that does the client feel like they can manage their own distress and trauma symptoms? And you will always have, and I say always, it's kind of frustrating for the client, but you might always have some type of trauma trigger or trauma response. And so it's learning how to manage it. But it is very effective to learn how to manage it and increase your window of tolerance to the distress.
Can I ask one more question?
Sure.
In church, when they talk about discernment, how do we untangle discernment from trauma response? Because a lot of times in like the prophetic realm and in church, they talk about like, oh, you'll feel things that may be disproportionate to what you're seeing in the moment, but it's like discernment. But a lot of this sounds like PTSD symptoms.
I'm not exactly sure. Do you have an example?
Yeah, like this may not relate, but like if your back starts hurting, you're like, oh, my back wasn't hurting a minute ago, but now it's hurting. Maybe the person next to me needs prayer for their back and God wants to heal their back. Like that feels like a break with reality, but it's also called discernment and prayer for healing in our circles. So is there an overlap between discernment and PTSD symptoms?
Yeah, so one thing that you'll learn is in order to meet the criteria of PTSD, the symptoms have to correlate to the trauma. And so if an individual's back's hurting and it's a somatic response, I'd be curious to know how that somatic response directly correlates to the trauma. So PTSD symptoms, which we're going to learn about in a little bit tonight, the symptoms have to connect to the trauma. So let's say you don't really have a traumatic history, especially around like a back or a back injury, and then your back starts hurting. I would be careful to diagnose that as PTSD, especially if there's no other symptoms, if there's
Okay.
no other PTSD or trauma symptoms.
Like sometimes when I go into like new agey stores, I'll either start getting dizzy or the top of my head will start tingling, and I won't even know that. And I'll start looking around and start seeing like crystals and new agey stuff that I didn't notice before.
Yeah.
And I'm like, well, is that PTSD? Because I've like been around that in the past in a traumatic way, or is that just discernment and like my ability to pray and invite Holy Spirit in that situation? It just
Yeah.
feels a little sticky. Anyway.
Sure. So what I would do if a client came in with that same presenting problem, I would do a full PTSD assessment and I would look for other things that are going on to determine if it's PTSD. So that in itself doesn't meet the criteria necessarily for PTSD, but if there's other things that went along with it, which we're going to get into in this class. Yeah, we're going to get all to that in a minute here. So one of the most frustrating things for the therapist is the main symptom of PTSD is avoidance. A client is not going to want to come in and talk about their trauma with the therapist. And then a brand new therapist can get frustrated and they're like, but I want to treat the trauma. So it's understanding how much a client does not want to talk about their traumatic incident. They want to avoid it. That is one of the main symptoms. So I'm going to teach you how to recognize it and what to do with it. The absolute worst thing you could do as a trauma therapist is to force the client to talk about their trauma. Say it one more time because it's so important. The most important thing, this is why it's important to recognize if a client does have a PTSD diagnosis, because avoidance is the number one symptom. The reason why they have avoidance is because they don't have the ability to cope. They haven't learned coping skills yet. And so they shove it down. And so the worst thing you could do is to force them or to make them talk about their trauma when they don't have the coping skills yet. You can absolutely re-traumatize your client and you could cause harm. Does anybody have any questions about that or thoughts?
I do.
Yeah.
So in doing SISM debriefs, the first thing that you kind of do is talk about what happened to like in that event. So that seems to go almost opposite of what you're saying.
So can you expand on that acronym?
SISM, critical incident stress management debriefs.
Great. So
And
you're
so,
sorry.
yeah, for example, we're doing a trauma class. So here, a warning for people, right? We went on a DOA for an infant who was 2 months old. So then they gather all the officers, the chaplain, everybody who was involved on that, and you do a round table. These are the facts so that nobody's brain is importing, like even the dispatchers come.
So that actually is talking and processing the traumatic incident is probably the healthiest thing you could do right after a traumatic incident happened.
Okay.
It's very healthy and beneficial to process and talk about it. The problem is that if an individual doesn't have a support system or doesn't have an individual to help them talk about it right after the traumatic incident happens, and if they're not given psychoeducation or not given permission, then you shove it down and you avoid it, and then you shove it down.
Okay.
And so for PTSD is a person's inability to talk or process or handle the trauma, so it's stuck inside them. So the first course of treatment would be to provide psychoeducation to the client and to increase their coping skills. But right after the traumatic incident happened, a person would not meet the criteria for PTSD. That would just be a traumatic event that happened. And of course, they're going to be experiencing strong emotions and strong feelings and distress. And the absolute most healthy thing to do is to process and talk about it. But that doesn't happen often when somebody experiences something traumatic because of the shame associated with it, because of the nature of it. They don't talk about it. They keep it to themselves. They withdraw, they isolate. And then that happens and your body remembers, and then you'll learn about in Dr. Van der Kolk, the body keeps score. Then you start getting PTSD symptoms. So I would say that for the dispatchers and the work with first responders, they probably will not have PTSD from that event because they're talking and processing it. Yeah.
Is
Which
that the same for delayed onset?
well, it's so kind of we're going to talk about how to treat it, but if somebody meets the criteria for PTSD, that tells us that the traumatic incident it happened some time ago, which we'll learn about that time frame. And so whether it happened 4 months ago, 5 months ago, years ago, the first intervention is to increase their coping skills and to increase the window of tolerance to the distress, because the ultimate goal is to process and to get them to talk about their trauma. But if we do it too quickly, too soon, when a client doesn't have the coping skills, we're going to re-traumatize them.
Right. You were just talking about, you're saying it's the most healthy thing to process it and speak about it right away. But if someone has already been traumatized and they're re-traumatized by the event, they may not be able to talk about it right at the moment.
It depends. If let's say,
Or will they? I don't know.
it honestly depends on so many factors. But let's say a first responder had their kid die in a car accident, and then they didn't process and talk about it. So any other traumatic event that they encounter is fine. But then let's say they respond to somebody dying in a car accident, that could trigger them. So the goal is to eventually get them to process and talk about the trauma. But if they meet the criteria for PTSD, that is the absolute worst thing to do. Because what that tells us is the client hasn't developed enough coping skills in order to handle and process the trauma. And so what we're going to learn in this class is we're going to learn how to recognize it, and then it's about gradual exposure. So you gradually increase the client's window of tolerance and gradually increase the client's ability to cope with the trauma triggers, so eventually they can process and talk about it. But guys, we'll get into all that. I know I love how enthusiastic you guys all are, and we're getting into all these details about how to. Okay, so avoidance is one, also re-experiencing. And now it is automatic. The clients don't want this. They don't want the re-experiencing. They don't want the flashbacks. They don't want the nightmares. But it just comes. It's intrusive. So intrusive thoughts, intrusive memories, nightmares during the day, and you can just be walking along the street, boom, flashback. That is another symptom of PTSD. Another one is hyperarousal, is constantly on edge, feeling like you can't let your guard down, like you can't settle, you can't have peace. And then also negative alterations in mood and cognition. So feeling depressed, feeling anxious, cognition, it's feeling like the world is not a safe place. I can't let my guard down. We'll learn about them in this class, but they're called stuck points. They're things that we tell ourselves about ourselves, others in the world that keep us stuck. So here are the main symptoms of PTSD we want to look for. So if you have a client that comes in with a trauma history and they don't have a problem and they don't have re-experiencing it, they don't have intrusive thoughts, they don't have intrusive feelings, they're not avoiding it, they don't have hyperarousal, they probably don't meet the criteria for PTSD. Here is the DSM, the diagnostic criteria for PTSD. And this is what you're going to need when you do your case study in a couple of weeks to determine if someone has PTSD. Next week, I go over acute stress disorder and I go over adjustment disorder, which also you'll learn how to diagnose and recognize in this class. And how you treat it is going to have some similarities and some differences. For example, for somebody that maybe meets the criteria for adjustment disorder and they have a ability to tolerate the distress, I might talk about their traumatic incident a little bit faster versus someone that has severe PTSD, then I won't talk about the traumatic event, which we'll get into more. I know I keep saying we'll get into, but it's just, yeah. I'm doing an overview right now, and then we're going to detail in the next couple of weeks. So in order for somebody to meet the criteria for PTSD, they have to have one or more symptoms in the following criteria. So it's criteria A, B, C, D, E. D, not D, E, F, G, H. So one, direct exposure. Kind of what Amy was saying as first responders, witnessing the trauma. Another one, learning that a relative or close friend was exposed to a trauma. Indirect exposure to adverse details of the trauma. What we're going to learn in this class is you being also in this profession, you could develop PTSD-like symptoms, especially if you constantly work with trauma. You could develop, it's called vicarious trauma. And there is a case study in this class about vicarious trauma. And we're going to learn how to recognize it and treat it and work with it. So don't freak out. We're going to, that's part of the assignments is to learn how to recognize it in ourselves. If somebody watches a television show, and let's say you watch a television show about a murder, that does not meet the criteria for PTSD. Now, let's say what you see in television reminded you of what actually happened to you. That could cause a trauma reaction. But in order for you to meet the criteria for a trauma diagnosis, number one, direct exposure, witnessing the trauma, or learning that a relative or close friend was exposed to the trauma, or indirect exposure. Criteria B is that it's consistently re-experienced in the following ways. And this is not voluntary. They don't want this. It's intrusive. It's automatic. It just comes. Nightmares, flashbacks, emotional distress after exposure to the traumatic reminders, physical reactivity after exposure to the traumatic event. Criteria C, avoidance. You don't want to talk about it. You want to avoid stimuli. You want to avoid thoughts, feelings. You want to shove it down. Say a traumatic event happened on Halloween night and you want to avoid all things Halloween. You don't even want to look at a pumpkin because the pumpkin reminds you of the traumatic event. You want to avoid it. Criteria D2, negative thoughts or feelings that began or worsen about the trauma. Usually negative feelings about oneself, about others, about the world, such as the world is not a safe place. I can't let my guard down. I can't trust people. I must have done something to cause this. It was my fault that the trauma happened. Because I didn't stop the trauma, I am at fault because I didn't say no. I deserved to be raped because I was wearing that short skirt. Do you get what I'm saying? So it's it's the distortions that we tell ourselves because of the trauma. So all of these symptoms, guys, have to tie back to the traumatic incident. If I have a client that's in distress, let's say they have intrusive thought about their dad yelling at them, but they don't report that as the trauma. Maybe their trauma is being raped by their uncle. Do you get what I'm saying? So you always want to make sure that you're matching the symptoms to the traumatic event. Okay, we have a difficulty concentrating, feeling isolated, negative effect. And then criteria E2 is trauma-related arousal and reactivity that began to worsen after the trauma. So hypervigilance, difficulty sleeping, difficulty concentrating, startle reaction. Now, this is the kicker, guys. The symptoms have to last more than a month, and they have to cause significant distress and impairments in functioning. If a traumatic incident just happened, the next day, you should expect majority of people to have some of these trauma responses. It's a normal response to an abnormal event. Where it meets the criteria for PTSD is if the symptoms last for more than a month and it causes significant distress in their functioning. It causes the client significant distress and impairs their ability to function. What that tells us is the client doesn't have the coping skills and they don't have the resiliency and the tools to learn how to deal with their trauma. So then that becomes the interventions in the work that we do. We help them with their coping skills. We help them to build resiliency. We give them a support system first and foremost before we process the trauma. Any questions about the DSM criteria for PTSD? Sarah, yes.
Yeah, sorry for coming in late.
Okay.
I had a thing that I had to do really quick. Anyways, I'm wondering what the difference is between like chronic PTSD and complex PTSD.
There it is. One thing that we'll learn about is it is subjective, but if somebody has had multiple traumatic incidents, I used to work with kids in foster care, and the kids in foster care that had PTSD because they've experienced something traumatic often had pretty big symptoms. And the symptoms they experienced usually got them taken out of foster homes because the foster parents weren't equipped to handle them. And so they constantly got moved around to house to house. Well, they would have chronic PTSD because they kept getting re-traumatized with having to change primary attachment figures. So it usually is multiple traumatic incidences that have happened and a client's inability or they weren't able to heal and process from the traumatic event, the traumatic events kept coming. Okay, so let's do a quick case study. So Emily, 10-year-old female. Well, let me just do check-in. How's everybody doing? Is anybody feeling traumatized or triggered? Is everybody okay? Just do a quick pulse check. How's everybody? Good? Maybe not so good? Not. Like even hearing this content right now, is anybody feeling in distress? Are we all doing good?
Good.
Good. Okay. All right. So we have Emily, 10-year-old female, referred by her mother, Sarah. This happens often, guys, at my practice. But Emily, 10-year-old female, referred by her mother, Sarah. Emily's 4-year-old brother drowned at a pool at a family barbecue 4 months ago. Emily's presenting problem. Cries at home and at school when she thinks about her brother. Sarah reports that Emily is preoccupied with death and will ask questions about why her brother had to die and talks about the drowning incident often. Sarah's overwhelmed by Emily's constant questions and doesn't know how to help Emily heal. When Emily is playing outside, Emily will freeze when running near a pool of water and start running the opposite direction. Sarah has refused to step outside since the accident happened and experiences overwhelming anxiety when Emily is near water, leading her to become overprotective and restrict Emily's activities. Sarah reports to sleeping often, experiences fatigue and mood swings. When Emily starts to talk about her brother, Sarah will try to distract Emily by putting on a TV show and feeding her ice cream. She's bringing Emily into therapy because Emily doesn't seem to be getting over the death of her brother. Does Emily meet the criteria for PTSD?
No, her mom might though.
How come? How come
Because
Emily doesn't meet the criteria for PTSD?
because she's trying to talk about it and her mom's trying to avoid it.
Yep. Anybody else?
She might not be talking about it, but she's still avoiding some parts of it. Like she's avoiding running near a pool. She's like running in the opposite direction. She freezes, right? Like, so she's not, we're still seeing some of the criteria is met, but it doesn't talk about, well, I guess the flashbacks could be like when she's thinking about she's thinking about the stimuli and then that makes her cry. She has an emotional reaction to it. They both, to me, they both meet the criteria for PTSD, I
So
think.
this is when we're going to go back and look at the DSM. So based on the DSM, does she meet symptom and criteria A, criteria B, criteria C, D, 2, E, F, G, H?
It's only been 4 months. Doesn't meet the time frame, does it? Have to be over 6 months?
So symptoms last for more than a month.
Oh, a month. I actually can't even see that. It's so small.
Oh, so
That
small,
number
sorry.
right there, so I don't know.
So this is an example of a traumatic incident happened to Emily, and of course she is impacted by it, but Emily does not meet the criteria for PTSD because she does not meet the criteria for all of have a symptom in each of these criteria. The mom, however, like Jessica said, meets the criteria. It's how it's impacting the mom. It's impairing her ability to function. Emily is in distress, but Emily is still functioning. Emily is still trying to function. She's still going to school. She might think about her brother. So Emily is more dealing with grief and loss over the brother versus PTSD. Sarah meets the criteria for PTSD because she is avoiding it, doesn't want to talk about it, won't go outside, seems to be depressed, is not helping her daughter process and talk about it. So Sarah meets the criteria for PTSD. Emily might meet the criteria for a grief and loss. And she might not even meet the criteria. She might meet it for adjustment disorder. That's something that we'll learn about next week. I go over into more details about adjustment disorder and acute stress disorder. Any thoughts about this or questions?
Yeah, as the therapist, how do you address that when Emily is your patient, but you see that actually the mom probably needs more help?
So interventions are week 3.
Cool.
If I go into the whole course, I don't know if I'll have we won't end in time, but we definitely go over interventions in week 3. Well, some in week 2. I'm not going to play the video for time, but we do have this video is in week this week's one folder. Understanding the physiological and hormonal response to the trauma. Now we're going to talk about a crisis. So a crisis is different than a traumatic event. A crisis is the perception of an event, a situation that is intolerable to the client and it exceeds a person's resources or coping skills. Can somebody give me an example of a crisis situation that's different from a traumatic event? Somebody that hasn't talked yet. If you don't want to talk, you can put it in the chat. What is the definition of a crisis, something that's a big crisis situation? How about your car breaking down? Well, that would be considered a crisis situation for somebody.
It could be, or a divorce, or lose a job.
Divorce. Yep. The loss of a job.
Mm-hmm.
Now, how could, let's say, if an individual's parents died, what would be the difference between a crisis situation or a traumatic event if someone's parents died?
Well, if they passed away of old age, that's one thing. But if there was a horrible accident or something catastrophic happened.
Yeah. I think, Steve, were you talking about the incidences with two? I've lost visual of a lot of you. Were you talking about the incident with the military?
Yes.
That you, what do you think? So back to your story, the situation, it's some individual, and that might be more traumatic, but it exceeds a person's resources and coping skills. Can you talk a little bit more to your experience to kind of highlight the coping mechanisms that individuals used where they were able to work through that traumatic event easier?
Well, for the one that was sent home, I really can't speak to that. I talked to him later, and I think it ended up being the fact that he knew that that it was happening to, like he created a bigger trauma than what we were actually going through.
Hmm.
And that's why he had problems. But for us, because like I said, we had such thorough training and we like trusted each other, when things were going on, we had each other's back. We trusted each other's movement. So we were able to process through it more as like just another day of the job.
So you had training, you had a support system, so you actually
Yes.
had more resources and probably more coping skills than the buddy.
Yes.
Does anybody have another situation of a crisis event that you've gone through and you had adequate resources and coping skills to help you go through that crisis? Anybody have a situation?
I've had a few situations
Sure.
at work dealing with crises and like clients. Work at a treatment center, so there's a lot of crises all the time. Specifically the fires that happened in last year.
Hmm.
That was a big crisis, but we had a team that we were working with. I had the program director and the therapist stepped in to do crisis management, so there were resources there.
Cool. Thanks for sharing. So, when you have somebody that's experienced a crisis, it is appropriate to process and talk about the crisis situation as an intervention. If somebody meets their criteria for PTSD, then you would not want to talk about the traumatic event until you can ensure that an individual has enough coping skills and is able to tolerate. And one of the things that we'll learn about when we're diagnosing PTSD and trauma is we want to focus and highlight on the symptoms that causes the clients the most distress. So looking at back to the PTSD symptoms, we want to, and there's an assessment that we're going to learn in this class is what is you want to go over with the client like a PTSD assessment and you want to highlight the client's trauma responses and trauma symptoms. So the goal in treating trauma is to ask the client which of these symptoms are causing you as the client the most distress, and then you will teach them coping skills and how to treat those trauma responses in week 3 and in week 4. We'll talk more about the how to. With stress, symptoms of stress, fear, anger, sadness, changes in appetite, difficulty concentrating, difficulty sleeping or nightmares, physical reactions such as headaches, body pain, stomach aches, chronic health problems, increased use of substances. So they're trying to cope with the stress. The difference between a crisis situation and PTSD is PTSD has to have the traumatic, it has to be considered a traumatic event, which is what we talked about earlier. What defines a trauma? Emotional signs of stress, feeling overwhelmed, hard time relaxing, feeling frustrated, agitated, feeling depressed or lonely, a sense of worthlessness, self-esteem. Now, if I have a client that's coming in and presenting signs of stress, I'm absolutely going to assess for PTSD. But if I can't tie it back to a trauma, then they won't necessarily meet the criteria for PTSD. They might meet the criteria for acute stress disorder, which we will learn about acute stress disorder next week. But what I'm trying to point out is there's a difference. There's a difference between PTSD and acute stress disorder and adjustment disorder. Here are some physical signs of stress. How many of you guys feel this way now in grad school? Difficulty sleeping, muscle tension, upset stomach, headaches, rapid heartbeat, losing one's sexual desire, feeling overwhelmed, hard time relaxing, feeling depressed, feeling worthless, avoiding other people, um, extreme pessimism, negativity, finding it hard to focus, feeling disorganized, poor judgment, racing thoughts, increased sense of worry. How many of you feel stress from going to grad school, working full time, trying to navigate a family, all life's responsibilities. How many of you are feeling a little bit of stress? Behavioral signs of stress, increased use of substances, eating changes, nervous habits, fidgeting, pacing around, avoidance. So it can look like there's some PTSD, but what I want to assess for is this stress because of a crisis situation or a stressful event, or is it full-blown PTSD? So that's what we're going to learn more in this class. And how do I differentiate between all of these diagnosis so I know exactly how to treat them and what interventions to give them. Okay, so here's what we're going to be covering in this class. I think I took out reactive attachment disorder only because you're not going to be seeing a lot of that in your field. You might see some of it, but it's not as common. Almost everybody is going to be treating somebody with PTSD, acute stress disorder, adjustments disorder, and an anxiety disorder. I do highlight reactive attachment disorder, but your case studies will only have either PTSD, acute stress disorder, adjustment disorder, and other anxiety disorders. Those that we're going to cover. Next week, I go into more detail about all of them. And so when you're doing your case studies, these are the diagnoses you're going to pull from. And when you do your group presentation, these are the diagnoses you're going to pull from. You're going to learn how to recognize them. You're going to learn what separates them. You're going to learn the differences between them. And then you're going to learn very specific interventions to apply to your clients if they meet the criteria for these disorders. Any questions so far, thus far?